Okay, now, most of the time we still survey low grade. We keep people under surveillance. How comfortable are we doing this? Well, again, a lot of this literature is based on older resolution white light colonoscopy, but here's what we know. As I said, there's a 20% chance that you're missing a cancer already. If you wait 5 years, there's as much as a 23 to 50% progression to high grade or cancer. An important concept is that only one focus of low-grade dysplasia, we think, is the same risk as multifocal. It's like being pregnant, okay? You don't have to wait for there to be multifocal low-grade dysplasia before the risk goes up because it may not happen. So very few studies have looked at that. I'll show you the one slide in a moment. But unifocal is just as likely to progress as multifocal. Once low grade is diagnosed, some patients say, or doctors say, you know what, I'm not sure I believe that there was low grade there. I'm going to do another colonoscopy in 6 months, and if there's no dysplasia, maybe it was a mistake. Maybe it went away. Maybe I'm okay. No. If the second exam is normal, meaning no dysplasia, it doesn't lower the risk of subsequent dysplasia or cancer. We know that low grade doesn't have to progress through high grade to get to cancer. The other thing is chromoendoscopy clearly finds more dysplasia, but we don't yet know whether that changes anything. I'll get to that in a few minutes. And there's an entity that I'd like to share with you, and the pathologists in the room are aware of this, but not all the clinicians are. There's an entity that Dr. Harp has at my institution, has termed low-grade tubuloglandular adenocarcinoma. It's a long, complicated term, but it basically is a type of colon cancer that seems to occur only in IBD patients, or primarily in IBD patients. Dr. Harpaz tells me he doesn't see this type in sporadic colon cancer, Lynch, or FAP. These are cancers that arise directly from low-grade dysplasia. And I'll show you if my images will transfer. I'll show you that in a moment. So here's the unifocal, multifocal argument. Okay, this is work from Tom Ullman at our center. And basically, he looked at the 5-year rate of progression in people who had unifocal low-grade versus multifocal, and the curves are superimposable. So we think that even unifocal has a similar risk to multifocal. This gets to the issue of what if the second exam is negative for dysplasia. This is an older study from Bert Korolitz at Lenox Hill, where they took all of their patients under surveillance, and they found that 22% had dysplasia. The ones that had a polyp or a cancer went to colectomy. So they were left with 22 low-grade dysplasia patients who stayed in surveillance. On the next exam, and the interval might have varied, but at the next colonoscopy, 69% of them had no dysplasia after the initial finding of low-grade. Were they out of the woods? No, because if you look at the subsequent exam, 40% of them still went on to dysplasia. 3 of them had cancers. In fact, the 3 of them had cancers in 5 to 10 years without going through high-grade dysplasia. So having dysplasia, then not having it, doesn't mean you're going to continue to not have dysplasia. You may still get it again. Okay, this slide from Tom's study shows that you don't have to go through high-grade dysplasia to get cancer. This is the 7 patients who developed cancers in our program, and you can see the various stages. 1 patient under surveillance developed high-grade, which prompted the colectomy that found the surprise cancer. But all these other patients remained in surveillance and had no dysplasia, indefinite, low grade, and then boom, cancer. Okay, no high grade. And in fact, the 2 patients that had node-positive cancers, the colonoscopy that preceded the detection of the cancer had no dysplasia at all. So patients can peter along, have dysplasia, no dysplasia, and then all of a sudden, have cancer. Low-grade tubuloglandular adenocarcinoma. So again, this arises directly from low-grade. It's associated with IBD. It accounts for 11% of the cancers that we see in IBD. It can be found in UC or in Crohn's, and some people have more than one of these things. There can be multiple. And it's rare that we find this preoperatively. It's usually done, oh good, it transferred. Okay, so here's a slide that I lifted from Noam Harpaz and Gabe Levy's paper from a few years ago. So here's a colectomy specimen. You can tell from the depth. When we biopsy the colon, our biopsy forceps go about this deep. Right? The muscularis mucosa is somewhere around here. If you biopsy this, anybody in the room would say that's low-grade dysplasia. Not very interesting. But this low-grade dysplasia is invading. Okay? It's clearly going through into the wall of the colon. And when you look at these glands under higher power, these glands are very innocent looking. They're very benign looking. The nuclei are really pretty homogeneous. They're not piled up. There's a lot of cytoplasm. There's very little desmoplastic reaction. They look like they're behaving themselves, but this is in the muscle. Here's muscle fibers. So this is an invasive, kind of benign-looking type of cancer. And we think now maybe this could be one reason by which people with low-grade dysplasia might have a surprise cancer. There could sometimes, and I don't like to even raise this because it scares people probably, but it's possible that maybe sometimes with low-grade dysplasia you've got a cancer already underneath it or not too far away. So it's an entity that I think we need to be aware of. Every time I give a talk, I try to make clinicians aware of this entity. Maybe Henry can talk about that at the end and shed some more light. Now, what about indefinite dysplasia? Not every pathologist of the country even uses the term because it means different things to different people. When you have an expert pathologist like Henry, or at my center, I'm lucky I have Noam Harpaz, if somebody really can reliably interpret indefinite dysplasia, it is a separate entity. And we went back and looked at our natural history at Mount Sinai of people who have indefinite dysplasia. And here's the here's the progression rate. This would be 5 years. Here's the progression of people who never had dysplasia on multiple exams. These are people who had indefinite. There's about a 14% 5-year progression rate to getting high grade or cancer. Now, I don't have the low grade curve, but if you remember from before, our data goes up to about 53% at 5 years. So low grade is up here somewhere, and indefinite is somewhere in between. So we do feel that indefinite is a bona fide entity. It really is different from no dysplasia. It's not as bad as high grade, but it is something to pay attention to. Let's spend a minute or two talking about chemoprevention. The data is mixed in many studies, but the one thing that seems to emerge clearly of all the agents that have been looked at is ursodeoxycholic acid. And that's in the PSC patients. So there's been 2 or 3 nicely done, actually prospective studies that show that people with PSC who take urso have a lower risk of developing colorectal cancer. Okay, the problem is only 5% of IBD patients have PSC. We don't know whether giving urso to everybody with IBD would lower their colon cancer risk. It would be an interesting study to do. There's a little bit of data that Dean Brenner, I'm sure, is aware of. In the general in polyp prevention studies, urso has been shown to lower the risk of future advanced adenomas in the sporadic population. So there's some tantalizing evidence that urso not only works in PSC patients, but might even work in the general population or those with IBD. I think in the general population, because you can get diarrhea from urso, people may not be too keen to use it. But you take a colitis patient who's having 4 or 5 bowel movements a day anyway, they might not blink. Okay, 5 ASAs. Can't go into all the details. The data are mixed. I think in balance, 5 ASAs do work, and I'll show you some of that data, but it is mixed. And if anybody cares, they can go to the technical review, and there's a table that lists every study that's been done in this area. 6-MP azathioprine don't lower your risk of colon cancer, as best as we can tell. There's a neutral effect. They don't increase your risk, fortunately, but they don't seem to lower your risk. There was a study presented at DDW last year from the French group, but they really didn't comment on their duration of use and the dosages. They claim that 6-MP and azathioprine do lower your risk of getting colon cancer, but I need to see the primary data before I can really be sure. Folic acid, it's never been shown in a statistically significant way to lower your risk. People say it's cheap, it's a vitamin, whatever, use it. No data on biologics. Okay, the 5 ASA literature, this is a meta-analysis from Fernando Velayos from a few years ago. I think the data still applies. What you can see here is he looked at all the studies, cohort case control studies that looked at whether 5 ASAs may be chemopreventive, and if you look at the bottom line here, it seems to lower your risk somewhat, maybe to the tune of about 0.5, 0.6. Again, not every study has shown an effect on cancer, and in fact, a lot of studies hadn't even looked at dysplasia as an endpoint, just cancer.